This episode is brought to you by Penumbra, innovating with purpose.
Welcome to the next episode of Legends and Luminaries in Endovascular Surgery. I'm Dr. Billy Cohn. I'm going to be hosting today. Usually, Zvonko Krajcer, who's here with me, is the host of this podcast, this series that he's created. But we thought if he was interviewing himself, it would look like he had some sort of mental disorder. So I'm stepping in his stead. I'm going to introduce you, and then I've got some questions for you. Does that sound okay?
Yep.
So Dr. Zvonko Krajcer, who I know well and have worked with for decades, is of Croatian parentage. He was born in Maribor, Slovenia, and lived in Zagreb, Croatia until 1970, when he immigrated to the United States. Dr. Krajcer completed his internal medicine and cardiology training in 1975 at Northwestern University and cardiology training from 1975 to 1977 here in Houston at Baylor College of Medicine. Since 1977, he's been part of the teaching staff at the Texas Heart Institute and Baylor St. Luke's Medical Center in the Department of Cardiology, where he has trained countless physician scientists for the next generation of interventional cardiologists. His leadership and commitment to research and education is globally impacting the care of patients suffering from cardiovascular diseases. Dr. Krajcer is an internationally recognized pioneer in the endovascular space of aortic aneurysms, and I can tell you personally, he's the last court of appeals here at Texas Heart Institute. We send him all the really challenging cases. He's a founding member and a former president of the Texas Heart Institute Cardiac Society. He's a past president of the International Society for Endovascular Specialists, which is dedicated to advancing vascular and endovascular therapies. As a program director, he's organized over 20 national and international meetings and has given over 1,000 presentations at national and international meetings. He serves as an editorial board member of several prestigious cardiovascular journals and as editor-in-chief of the Texas Heart Journal. He has participated as a co-investigator and principal investigator in multiple clinical trials for the treatment of peripheral artery disease, abdominal and thoracic aortic aneurysms, carotid artery stenosis, venous disease, heart failure, and percutaneous valve heart therapies. I can tell you he's also involved in a percutaneous trial for a morbid obesity technology that he's been incredibly helpful with. He's performed over 5,000 EVARs, TVARs, and TAVR procedures, and thousands of other interventional procedures. He's one of the pioneers of percutaneous endovascular aneurysm repair, which uses a fast-track protocol by using local anesthesia and a percutaneous approach. He's published over 200 publications in peer-reviewed manuscripts, in peer-reviewed journals. He's the program director of the Texas Heart Institute Technologies and Techniques Educational Program, and more recently, this podcast, Living Legends and Luminaries in the Field of Endovascular Medicine. I count him as a great friend. He's a great resource when you're working on challenging cases, and it's a delight to get to interview you. Welcome, Zvonko.
Thank you. Thank you very much, Billy.
So, like you did when you interviewed me, let's start from the very beginning. Why did you decide to go into medicine? What were the main factors and the influencers that put you on this path?
Well, Billy, when I was 16 years old, my brother-in-law, who was a physician at that time, Dr. Tony Franovic in Croatia, in Zagreb, gave me a book, General Introduction into Psychoanalysis by Freud, Sigmund Freud. And that book was absolutely fascinating to me, as you imagine, a 16-year-old reading about and trying to analyze your dreams, learning about ego and it, and learning about just psychology and psychoanalysis. And it was a tremendous impact on my desire to learn more about this and about medicine. And then the second stimulus really was, I would say, coup de grace in making a decision to become a physician when I was this was obligatory in high school to write a thesis before you graduate, and this was a verbal presentation, and I chose to write about endocrine system in invertebrates.
Wow.
So, of course, I had to do a lot of research. I learned about endocrine system in plants and animals, and the specific topic was invertebrates. So obviously, I had to read a lot of books, a lot of publications on it. And so I defended my thesis very well, and it was an excellent type of, exception. So I was really honored when professor told me this is one of the best presentations and theses that we have seen in the decade. So that kind of stimulated me to decide to go into medical school.
This thesis was while you were in high school?
High school, right? Because
Wow.
Well, because high schools in Europe were different. Gymnasium.
Gymnasium.
So this is almost equivalent to a college type of
Got it.
education. And the requirements are very rigorous. I mean, in physics, in biology, in chemistry, and so on.
Now, after reading that Sigmund Freud book, did you ever consider going into psychiatry?
I did, as a matter of fact. And so then I decided, well, maybe psychiatry and psychology is not necessarily as exciting as neurology. And as a matter of fact, when I was a fourth-year medical student, and that was in 1968, in Zagreb, if you have very good grades, you were allowed to go abroad for a so-called externship during the summer for 3 months. And there were several universities in Europe that were offered to us for that. And I decided to go to Denmark, to Copenhagen, to one of the hospitals that had a tremendous reputation in Department of Neurology. The name was Bispebjerg Hospital. It still existed. That hospital was built in 1915. And so when I was in Department of Neurology, this is really in 1968 where I was for the first time presented with an opportunity to get involved in intervention. What we were doing at that time, and I participated in those procedures, we were measuring cerebral blood flow with xenon-133 with 16 electrodes placed over the location of the middle cerebral artery in different conditions such as acute stroke, schizophrenia, patients with bipolar disorder, patients with malignancy, and so on. And so the neurologists in that particular department were interested in figuring out how we can alter cerebral blood flow with an intention to improve the condition. So for instance, if you have a stroke, should you be improving the blood flow to heal the brain, and with a variety of different maneuvers, giving oxygen, giving CO2, giving aminophylline, and so on.
Sure.
So when I finished my training after 3 months there, and I was performing procedures with them, that was allowed at that time, even as a student. And the procedures were interventional because that was before catheterizations the way we know it at the present time. So we were doing a direct stick into the carotid artery using a Seldinger needle and then advancing the wire into, hopefully, in the internal carotid artery, putting a tiny catheter in there and injecting indocyanine green. If the catheter went into the external carotid, we knew because the face would be green. But if it didn't, then we knew we were internal carotid artery. So after several tries, once we achieved that goal to be into internal carotid artery, we would then inject xenon-133 and measure the cerebral blood flow and then give different drugs. So that was my first.
What year is that?
68.
Isn't it amazing
1968.
how things have changed?
Right. Anyhow, so when I came back to my medical school in Zagreb, I published this in a medical journal there and received the first award from the dean for the best publication of that year, with an award of $500, which was a lot of money at that time. But anyhow, so that gave me an opportunity to do certain things that probably you are going to ask me more about.
But that's what drove you into interventional cardiology.
Right. But the next year, so in 1969, I went back to Denmark, the same hospital, But this time I wanted to learn a little bit more about surgery. So I got involved in the gastroenterological surgery department.
Okay.
And I was working with very reputable surgeons there. And basically what we were doing is a variety of different procedures. I learned how to do hernia repair, ventral, inguinal hernia repairs, and so on, how to tie different knots and so on. But another exciting thing that was interventional from my point of view is to do what we call a super duper vagotomy. And so you would actually make an incision, expose the part of the esophagus and part of the stomach, identify the vagus nerve, inject again into cyanin green to see the whole distribution of the vagus branches. That's why I call super duper vagotomy. We would cut every single branch there to decrease the acid production. That was the only treatment available for gastric ulcers and gastritis.
I remember that. Yeah.
So anyhow, this is where I learned a little bit of surgical
technique.
Right.
Well, I think we're all grateful that you went in interventional cardiology, but if you'd obtained some psychiatric knowledge, that probably would have been help navigating the Texas Heart Institute.
Right.
But anyway, so here you are doing all this research, getting all these accolades in Croatia. Why'd you leave Croatia?
Well, I wanted to learn more, and there were opportunities. So as a matter of fact, I subscribed to New England Journal of Medicine, and as you know, in the last page, I don't know whether that's still the case because I don't look at the last page. There are ads there,
sure.
And there were a couple of ads that kind of excited me, and one was from McGill University in Montreal in Department of Neurology. They were pursuing further research in measuring cerebral blood flow, but no longer with direct carotid stick, but a transfemoral approach and so on. Right. So I applied for that, and there was another application, and that was in Milwaukee, in the United States, in cardiology and cardiovascular surgery. And I said, well, I tried neurology, I tried gastroenterology, surgery. Maybe I should get involved in an interventional type of a field like coronary artery bypass surgery and the latest advances in cardiology. And I finally decided I'm going to go to Milwaukee. So I went to Milwaukee.
Was that when Dudley Johnson was
Dudley
still very
Johnson,
active?
right, at St. Luke's Hospital.
Legend. Yeah.
St. Luke's Hospital. And so that was 1970. And interestingly, at that time, Dudley Johnson was one of the leaders in the field. He trained at Cleveland Clinic, and he had tremendous results with surgery. But in 1970, his mortality with coronary artery bypass surgery was 8%, which is totally unacceptable at the present time. And you know what was the main reason of mortality? Pulmonary emboli.
Is that right?
Because all those patients, we didn't know at that time, but all of the patients were bedridden for 5 or 6 days.
Right.
We didn't use elastic stockings,
Sure.
and they developed thrombophlebitis and pulmonary emboli. So what I was involved in the Department of Radiology and Cardiology, we were doing pulmonary angiograms to identify did the patient have a pulmonary emboli, and then we were giving streptokinase whenever we could.
Directly into the pulmonary artery?
Exactly,
Yeah.
exactly. So those were the early beginnings of intervention.
Now, when you came over, I imagine, were you already fluent in English?
I was.
So
As
what
a
was
matter
it
of
like,
fact-
though, coming
As a matter of fact, by the age of 16, I was totally astonished by writings of Ernest Hemingway and Faulkner. I read all the Hemingway's books in English and Faulkner's books in English and so on. So I was pretty familiar, with literature in general and English language. Yeah.
So that made it a lot easier to come to the United States, but I'm sure there was a big culture shock. I mean, what was that like when you first got over here and went to Wisconsin, and did they say?
Well, so I had an opportunity to travel through Europe, so this was not necessarily the first time that I traveled outside of the communist country, Yugoslavia, because Denmark was pretty much advanced, and I was in Austria and Germany and so on. So it was a unique opportunity, but what really excited me is the education and the opportunity to learn more. in cardiology. So at that time, there was no intervention in cardiology. I remember, there was still a master two-step test for testing because the treadmill was not routinely used at that
Right.
time. There was apex cardiography, phonocardiography. I don't know if you heard about those things, but this is basically what we were doing, trying to figure out cardiac conditions, but no interventions at
So
that
when
time.
you would take that catheter, and how would this was before the Swan, how would you get into the pulmonary artery to
Just
inject?
navigating the wire, trying your best to get up there,
And when you had the catheter there, you'd squirt some contrast.
Yeah.
You'd see the clot. Did you ever
Exactly.
think, wow, I'm right there. We need to
Exactly.
develop a technology for grabbing that clot and pulling it out.
Those thoughts were there from the very beginning.
That's so
Absolutely.
great.
Absolutely.
So you're there with Dudley Johnson, and you're getting to go in the OR. You're doing this stuff with the pulmonary. Why'd you ever leave there? Because you went from there to Chicago, right?
Well, so this is a little bit more complex story, but in Milwaukee there was no university to the degree what Northwestern University would
see.
offer me for education, further education. So I was accepted at Northwestern, and it was a pleasure to be there, and I learned a lot. But this is exactly the time when Cooley and the Bakey were in news media, as you know.
Sure.
You mentioned
Right.
Dr. Cooley with a artificial heart in 1969. A lot of procedures, a variety of procedures, vascular and cardiac procedures, bypass surgery, valve surgery, and so on. So I felt like I'm not necessarily in the best environment to see all the progress that has been made in cardiology and also in cardiovascular surgery. And that was the reason that in the middle of my fellowship at Northwestern in cardiology, I had first 8 months of cardiology at Northwestern, I decided I needed to come to Houston. But, it's not easy to transfer from one
Sure.
program to the other. And I was fortunate enough to actually, this goes back to Milwaukee, to befriend and know one well-known individual that was actually one of the owners of Schlitz Brewery,
Okay.
which was a well-known brewery.
Sure.
Needless to say, he was a multimillionaire. And he had a cirrhosis of the liver with quite a bit of ascites. And while I was still in Milwaukee, I would be draining his ascites at least once a week, like 2 liters
Wow.
a week. So he was very appreciative of my efforts and so on. And so I would meet him periodically. He would come to Chicago during my training for a variety of events. And he always asked me, "Are you happy where you are?" And I said, "Not really. I would like to go to Houston if I could, but I know it's impossible." He says, "Nothing is impossible in life." I said, "How so?" He says, "Well, I know Michael DeBakey real well because he's the one that did my abdominal aortic aneurysm repair 6 years ago. And this is how I developed cirrhosis of the liver because I needed a blood transfusion."
Oh, wow.
And
You got
he
hepatitis.
says, I gave him several $1 million for education and training.
Wow.
And we talk periodically here and there, and I can give him a call and see if he can help you. So he did, and he talked to Dr. Bakey, and Dr. Bakey, said, "Send him over. We'll see if he's good enough to join our program."
Isn't that amazing? You never know what interactions
You
are going to
never
turn
know.
out to be super important in your life.
So
You
when
know.
I came for an interview, I know it was January of 1994, we had one of those perfect, calm, sunny days in Houston that sometimes happens in January. So I was immediately enamored with the
Leaving
beauty
Chicago
of
with the-
Chicago,
yeah.
minus 20, minus 30
Sure.
degree temperature. And so the first thing what I did is, because that was prearranged, I went to meet Dr. DeBakey at Methodist Hospital, and he
And
was
this is what year? 1973?
3. He was very
Wow.
kind to me. He says, "Oh, you are this gentleman's friend?" "Yeah, I am." Well, we have several institutions available. We have Ben Taub, we have Methodist, and We have St. Luke's Hospital, and you will rotate through all of them and go for interviews, and then you'll make a decision where you want to be. So, Dr. DeBakey was well known to be pretty harsh sometimes and rigid as far as taking care of individuals that he didn't want to waste time on.
Right.
And but he was very kind to me. So, but anyhow, so I rotated through all those for interviews, and I decided, actually having an interview with Dr. Leachman and Robert Hall, and also seeing what Dr. Cooley has done, that this is probably the best place, because even at that time they were doing 10 to 15 heart caths a day, while at Northwestern they were doing 1 or maybe 2 and so on, and a lot of open heart surgery. They were like that particular day, 25 pumps available. So that was absolutely impressive. And at Methodist Hospital, they were doing also 1 to 2 caths a day and significantly less surgeries. So I thought that Texas Heart and St. Luke's was a better choice for me.
And did Dr. DeBakey take offense? Because that was when they were
highly
polarized.
I was afraid to approach him. So as a matter of fact, I have never seen Dr. DeBakey during my training or my early career at Texas Heart Institute, and maybe I should have, but I was afraid to approach him because I'm sure he would have asked me why didn't I want to come to Methodist Hospital.
Right.
So the only opportunity that I had meeting Dr. DeBakey again was probably in 2000. And that was at the meeting in Tampa, one of the major meetings with 2,000 physicians. And my presentation was on percutaneous abdominal aortic aneurysm repair. And Dr. DeBakey was there as faculty, highlights of the whole meeting, and his presentation was on the DeBakey pump. So we were sitting together in the front row, and I introduced myself. I don't think that he remembered me from before,
Probably
honestly.
a good thing.
So he was the first one to give the presentation, and then I gave my presentation, and I feared that there would be either criticism or some kind of harsh comments about percutaneous repair. You know, he was inventor of abdominal aortic aneurysm surgical repair with tremendous history behind it and so on. But he was very kind to me. He says, "Great presentation. Can you send me your slides?"
Wow.
I will sure quote your name in it. So that was
That's
very
wonderful.
kind. And another thing is, before actually we left, he said, "But please send it to my personal email, because I don't know if somebody will steal it if it comes to the
Oh, my goodness.
Baylor."
Oh, my goodness.
So when I came home that night, I sent him the presentation. He immediately responded, "Thank you very much. I greatly appreciate it, and I admire your presentation."
Wow. Well, so tell me about when you first met Dr. Cooley, because DeBakey invited you down here, and then you went and somehow interviewed at St. Luke's, because there was a iron curtain between the two. And did Dr. Cooley sit down with you and say, what are your ambitions, what's your passion? How did that all work out?
No, that was not part of the requirement for fellowship program. Dr. Cooley was not involved in that.
Got it.
Actually, my involvement with Dr. Cooley is by sending my patients to Dr. Cooley for surgery and going, actually observing the procedure. And I was, like you were, mesmerized by his skills,
Sure.
by his knowledge, by his magical approach to surgery. As you know, not a single move was wasted.
Right.
He did it with such a calm, with such elegance, and with such expertise that I absolutely admired, his surgical ability, but also common sense. So at that time, as you know, we received patients from all over the world. And a lot of those patients were patients with abdominal and also cardiac aneurysms. But my particular interest was in cardiac aneurysms and post-infarct, typically. And he would perform annually up to 200 aneurysm, left ventricular aneurysm repairs.
Cooley endoaneurysmorphies.
Exactly. So I was interested in actually getting involved in this and reporting the data, publishing the data on that. So I did presentations for Dr. Cooley at American Heart Association, American College, and finally we published it in circulation, on several occasions. So endoaneurysmorrhaphy as a treatment of, the most effective treatment of left ventricular aneurysm repair. There was some disagreement, as you know. There was a door technique,
Sure.
there was Jetain technique, and so on. But of course, Cooley modified it to his own technique. And this is unique to Dr. Cooley because, as you know, his motto was modify, simplify, and apply.
Yeah.
But this is not an empty motto. This is a very meaningful motto.
Super
What Dr. Cooley wanted to do is he observed procedures, even when he did training with when he was in Boston with Blaylock, and what Lilly was doing, and so on. He always thought, whether it was in pediatric surgery or adult or whatever, how can we make it better? How can we simplify it? How can we make it more effective with good outcomes and patients' better outcomes? So that's where modify, simplify, apply comes from. And this is not a unique Cooley type of a process of thinking, because, Albert Einstein said, make it as simple as possible, but not simpler.
Right.
Or out of clutter, find simplicity, and many other thinkers of that kind.
Sure.
So he really embodied that approach in cardiovascular, cardiothoracic surgery, and did the best that anybody could do. So I truly admired, his ability, his achievements, and then I worked with him on hypertrophic cardiomyopathy, mitral valve replacement for hypertrophic cardiomyopathy. He also did a lot of myotomy and myomectomies, but sometimes they wouldn't work the most effectively, and there were certain complications related, such as VSD, complete heart block, and so on.
If you cut too much.
And a lot of those patients had a fulminant MR. So at that time, there was no classical technique that exists.
And it was Morrow at the NIH that
Morrow,
that.
Exactly. So he had excellent results with mitral valve replacement. Of course, there was a lot of controversy and criticism, and I received most of it because I presented those informations at the meeting, American Heart and American College. But so that was another area of interest that we worked together.
So let me ask you this. As you started to champion and pioneer a lot of the endovascular aneurysm repair, EVAR, I remember the first time I heard a presentation about it, it was Craig Miller presenting at a meeting here in Houston, and Denton Cooley had introduced the talk before, and before introducing Craig Miller, he said, and now from the sublime to the ridiculous. So he thought there was no future in EVAR. At some point, he totally switched and thought it was brilliant. Did you, you're championing it? Is that how you converted him?
So this was in 1995. The only trial that was available at that time in EVAR, as you know, in 1990, Juan Parodi did the first abdominal aortic aneurysm repair in Buenos Aires, Argentina. And so I wanted to get involved in this field right away. I had some minimal surgical skills, as you know, and I wanted to create my own device because nothing was available. The only trial was the Ancure trial. And I came to Dr. Cooley and asked if he would be interested in maybe talking to the industry so we could be part of the trial. But the trial was closed. There were all vascular surgeons in that particular trial. There was no way to enter. So Dr. Cooley said, Zvonko, you have to create your own device. This is the only way how you're going to be able to do it. So I started working on it with commercially, clinically available products such as wall stent for transesophageal applications and transtracheal applications. It was 22, 24 millimeter in diameter, 7 centimeters in length. And I got some EPTFE material from Gore, made it ultra thin. I used the 6-Prolin and sutured to it, reconstrained it in a catheter. And actually, the first patient that I did was a patient of Dr. Cooley's, 79-year-old gentleman that had a well, I would call it almost end-stage heart disease with ejection fraction of 25%.
Right.
Post-bypass surgery, definitely inoperable with large abdominal aortic aneurysm. He asked me, "Can you fix this?" And we did it. And he was with me.
With that homemade stent
Homemade
with the
product.
EPTFE on it, and delivery system, you just put it in a big 16 French sheath.
Peel away sheath. No,
Okay.
it was 14 French.
Okay.
Which is at that time unheard of because Ancura was 27 French.
Right.
So Dr. Cooley was there. That was in room 8 here at Texas
And
Heart.
were you still doing a cut down in the groin?
No, there was no cut down. It
That
was,
was like for the first percutaneous
first
ones?
percutaneous ever.
Wow.
And
With a homemade implant.
With homemade device.
That's amazing.
Dr. Cooley was there. There was no anesthesia. It was all conscious sedation. Dr. Cooley just observed. He was not scrubbed in, but he was curious to see. And he just shook his head, says, "I cannot believe that." So, but it was
Lovely.
done. And the
Fantastic.
patient tolerated the procedure well. He walked out of the hospital 2 days after that. No
Fantastic.
consequences of any kind. So that was the beginning and probably the first percutaneous abdominal aortic aneurysm repair through a 14 French sheath under local anesthesia in cardiac cath lab.
Wow. And that must have really cemented the relationship between you and Dr. Cooley as
Definitely.
co-innovators. Were there a lot of other projects that you guys,
Well,
you talked about the myomectomy
They
stuff.
were.
and-
We traveled together to a lot of different meetings. He was in Croatia and several meetings where he was the star of the meeting, and I was organizing meetings, so-called, through International Society of Endovascular Specialists in Jackson Hole, and he came to gave a talks, but it was mostly educational projects after that we worked on.
You know, I mean, when you talk about Dr. Cooley, it strikes me, he was 1 in 100 million. I never met anybody like him. As you know, I was Michael DeBakey's last chief resident, and then the last decade, or actually, I came here in 2003, and I guess Dr. Cooley died 8 years ago.
Right.
But anyway, and I just an amazing man, and just watching him operate. I've heard Bud Frazier say there's no pilot alive today that could fly the Spirit of St. Louis from New York or from Paris to New York or whatever. I don't think there's any surgeon alive today that can operate like Dr. Cooley did. What was it that made him so magical? What was he a mutant?
Well, he had a unique set of skills, which is physical, technical, and mental. Number one, he was extremely calm. Dr. DeBakey was not a calm individual, as you know. He was extremely calm. He was rational. Every move was figured out in advance. And another unique thing about him was that he did not do unnecessary procedures. I remember when I was in Milwaukee with Dudley Johnson, he would perform 7 bypasses at the same time,
And these
also
huge,
do
long
endarterectomies.
endarterectomies. Oh my God, those are incredible.
Those procedures lasted for 8 hours.
And he would have a cut in the coronary 10 centimeters long.
Dr. Cooley's belief was
3
that
grafts.
no patient needs more than 3 bypasses, 3 territories, RCA, LAD, and circumflex.
He would say if you build 4 gas stations on each corner of the same intersection, you still sell the same amount of gas.
Exactly. So, and that worked for him very well, and worked for his patients as well. And another thing is that he was so efficient time-wise. When he was repairing the ascending aortic aneurysm, and for a lot of surgeons, this was a no-no, because, as you know, the brain does not tolerate lack
blood
of blood
supply,
flow,
yeah.
blood supply. And he would figure out, first he would use ice to put on the head to cool and constrict the blood vessels so there would be less demand for the blood supply to the brain. But another thing was speed.
He was so fast.
None of his total circulatory arrest lasted longer than 8 minutes.
Wow.
And typically, when I observed the other surgeons
40
doing
minutes. Yeah.
Exactly.
Yeah.
So that was the secret to his success and his achievements in whatever he would do.
I remember him saying the invention of cardioplegia to protect the heart so you could operate on it longer was the worst thing that ever happened to him because it made it so ordinary mortals could do heart surgery.
Exactly. And he did have a very dry sense of humor.
Oh, he was hilarious.
And sometimes it was a low voice, so you have to catch it
Yeah.
just the right way to be able to react to it and respond. Yeah.
I always felt like I was in the presence of a movie star.
And another thing is, which was very interesting, and that's true for many luminaries, that regardless in what field you are, but he had many associates, but a lot of them just couldn't keep up with his expectations, with the quality of procedures, with being expeditious enough and comfortable enough in being able to do the procedures what Dr. Cooley would expect them to do. So he was always very kind to his associates, but they felt like they were so inferior, and a lot of them left for that particular reason. The one that I admired absolutely,
David.
well, the one that
George.
I admired absolutely, that was also admired by Dr. Cooley, was George Rule.
Yeah.
George
Who
Rule,
just died 2 weeks ago.
George Rule
Yeah.
shared the office with Dr. Cooley, and George Rule was always reserved, similar like Dr. Cooley, had a similar thought process as far as surgery is concerned, and had excellent results. So I admired him, and he was a dear friend, and we worked together on many different projects. I remember when we started with coronary angioplasty, I remember one patient in 1981 that when I performed PTCA of the right coronary artery, and that was with all Grunsik balloon and caused dissection, and the patient fibrillated. We had to massage the patient on a gurney to the operating room, and Dr. Rule was waiting there, and he very expeditiously performed surgery. This patient is still living.
Wow.
He's still a patient of
Wow.
mine so many years after, so I was very thankful to him for a lot of things what we have achieved together. But one of the greatest things what we have achieved at Texas Heart Institute at our hospital was establish a rotating fellowship program between cardiothoracic surgery, interventional cardiology, and radiology. And this was active for about 10 years, where the physicians would rotate through all three specialties, and we were trying to create an interventionalist that will be well informed in all the fields of cardiovascular medicine.
Sure. That cross-training is essential.
Right.
It makes you a hybrid. You understand the field from different perspectives. It's very valuable. Now, you work closely with Jim Willerson as well. What was that experience like?
Well, Jim was very similar to Dr. DeBakey and Dr. Cooley as far as great minds are concerned, think the same, think alike, but also he was a relentless worker. He probably didn't sleep more than 3 hours a day, a night, and he worked very hard. He was a perfectionist
Yeah.
in many ways, but his ability to do a variety of things was absolutely fascinating. So I think what Dr. Cooley and DeBakey achieved in cardiovascular medicine, this is equivalent what Dr. Willerson achieved in cardiology. In so many ways, when he was editor-in-chief for Circulation for 11
14
years and was
14
housed,
years,
was housed here
Yeah.
at Texas Heart Institute, but in many other things that he has done through his, I would say, relatively short life, because he wanted to do so many more things.
And all the time, a super busy clinician, and he would give his cell phone out to all of his patients, and they would call him at all hours of the
Yeah,
night.
he was admired by his
Oh,
patients.
they loved him. They loved him.
Determined. He was truly determined and dedicated physician.
Now, talking about amazing characters in this field, you have just championed endovascular procedures and have really stretched those horizons. But Ted Terrific played a huge role in that. Ted Dietrich, who's a personal favorite of mine. What was your interactions with
So
Ted?
interestingly enough, Billy, if you would ask me who are the four individuals that actually influenced you in your life, professional life, I would say Dr. DeBakey, Dr. Cooley, George Rule, and Ted Dietrich. So, and all originated from here,
Wow.
from this small environment.
Sure.
And
Something
so,
special about this little pond, huh?
exactly. So, because you know that Ted was very closely associated with DeBakey, and DeBakey admired him, and so on.
Sure.
And but you know, it was time for Ted to do something on his own. So, you know, like the saying goes, DeBakey probably gave a hint to him, go west, young man.
Yeah.
And he did go to Phoenix, Arizona,
Right.
and established Arizona Heart Institute. And it did something tremendous in a relatively short period of time. But he was super intelligent, extremely quick in his ideas and actions.
Sure.
He was one of the best performers in
every aspect.
in every
Yeah,
aspect. I
right.
mean, he has his own TV station, radio station,
Right.
and so on.
He played in the band with
He
Dr.
was
Cooley,
the heartbeats here,
Heartbeats, yeah.
exactly. So he was very versatile and so on. And I got attracted to Ted Dietrich and his achievements, you know, through his international congress that he was organizing from the early 90s, and joined that congress and joined International Society of Endovascular Surgery at that time very early. And so I wanted to learn what he was there to offering, which was kind of very unusual. He was a showman, and not only in vascular and cardiovascular surgery, but in cardiology as well. He was encouraging his cardiology colleagues to do the latest innovations and so on. So, you know, in the late 80s and early 90s, there was so-called hot tip laser or argon laser.
Sure.
And this is where he had trained by Rod White to use that in peripheral applications, and I got involved in that as well. And then that's how we connected in early stages. But so he admired all the things that I have done. And I invited him to the meetings that I would organize here in Houston. And then I invited him to do the procedure. So actually, when I did live in 1995 or 96, one of those early EVAR percutaneous procedures, I asked him to come in the lab, cath lab, and assist me in a way.
Nice.
And he was admired what I did with surgical techniques in suturing that epithelial graft and so on. And so I was still using a C-clamp because at that time we didn't have a closure device like we have at the
Right, for
present
the groin.
time
Uh-huh.
to achieve hemostasis in the groin. So he says, I can help you with that. I said, how can you help me? I mean, I don't want you to expose the large segment of
Right,
the
put a
artery.
stitch in.
I don't want general anesthesia. He says, no, we can do it on the local. So he would make a small incision, about 2 centimeters, whatever,
Right.
and do what we call actually fascia suture.
Sure.
Per string fascia suture. It was so efficient and so quick.
But outside the vessel, it just
Outside
sort
of the
closed down,
vessel,
yeah.
just using cribriform fascia to close that access site, and that was the simplest thing that I couldn't believe that it could be done. But he perfected it, and it was very successful. So we worked very closely together. When I would go to Arizona Heart for his Congress meetings, I would also participate in either carotid artery stenting or access repair with closure devices later and so on.
Sure.
So we traveled together, and we particularly worked together on International Society of Endovascular Specialists meeting. We organized it all over the world, 3 times in Argentina, Puerto Rico, Italy, Croatia, Slovenia, Australia, and Middle East, Dubai, and so on. So we worked very closely together for a long period of time, and it's truly unfortunate that we lost him so prematurely because he had so much to offer.
Yeah.
And so,
Was a great man.
Right.
Very entertaining.
Yeah.
Now, you just mentioned carotid stenting. I mean, that emerged while you were at the peak of your game, and you were one of the early embracers of it, and it was hotly contested whether it was the right thing or the wrong thing. Now it's here to stay.
What was that like, being at the center of that controversy?
So again, it was going back to Dr. Cooley. He would receive a lot of patients from MD Anderson, post
Radiated.
radical neck
Yeah.
and radiation
Yeah.
with severe stenosis. And
He'd say, "Tag, you're it, Svanko."
he knew that there was a risk of facial nerve paralysis.
Sure.
There was a risk of infection. There was a risk of restenosis. He learned that a long time ago. So he says, Svanko, can you fix this by endovascular approach? So the first patient that I had was probably 1994, referred by Dr. DeBakey, and we did it percutaneously by femoral approach. At that time, we did not have dedicated stents and protection devices,
Sure.
so it was still done in a primitive way through a .035 wires and peripheral stents like wall stent and so on. But so that was the beginning. And then another patient shortly after that, I took to Phoenix, Arizona, to do it with Ted Dietrich because there was no access available because the vessels were occluded either from a brachial approach or from femoral approach.
So what'd you do?
So we did a direct carotid access, what
Just
I
like
did
yeah.
1960,
Nothing new under the sun, right?
1968
Right.
in Copenhagen, Denmark. And he already had a 5 centimeter long sheath, so it means he wouldn't go directly into the internal carotid. It was ultrasound guidance, and you put a needle, you put a wire.
Way down at the base.
Exactly, and put a stent in there, and reverse heparin and hold pressure for 5 minutes. That was it.
Wow.
That was direct
Wow.
carotid access. So later we did a similar procedures here. We used what we call at that time boomerang device, which is one of the closure devices,
Okay.
which basically is a nitinol like a
Before
ring.
per close? Is
Yeah,
it-
before per close,
Wow.
and that worked very well in those scenarios where you couldn't gain access via any other way. So that was a direct stick going back to history.
Fantastic.
Right.
Yeah, nothing new under the sun.
Right.
It's all reinventing and having new thoughts about it. Now, so you've been a champion and pioneer in EVAR and TVAR, and now I've seen some of your procedures where you do snorkels and this and that and custom branching and stuff. What's left to figure out? I mean, is it we got it figured out, or are there
Well,
still
so
unmet needs?
those are so-called branch endografts.
Yeah.
And
Custom
several
grafts,
several
I suppose.
companies produce them
Right.
and so on. Some of them are custom made. Some of them are bench devices that are available, and with certain improvisation and so on. They're still in early evolution, I would say, because we have so-called also physician-modified devices that we can create, basically deploying the device on the bench, using a cautery to make openings and
Ostiums
so on.
that line
Of
up
course,
with the
that's
branches.
time-consuming, and that's to a certain degree involved. There are certain difficulties that you might encounter because human body is unpredictable
Sure.
how those openings will
Move with
adjust
motion.
and so on. So I think the future is in those branch endografts, but we have to have options available, different scenarios, different applications. This is what I would call unmet needs because the industry will produce one product, but it does not fit all the patients. So there has to be an opportunity to have a variety of different products available. Another thing is, and you are directly involved in this, some of those materials that we have at the present time are 50, 60, or 70 years old.
Right.
Remember when Dr. DeBakey went to the store to buy
Foley's.
a Dacron material?
polyester, yeah.
Not polyester. Nothing has changed.
Right.
Dacron polyester has certain impurities, causes fibrointramural hyperplasia, fever, and so on. It's not very pliable. It's not biocompatible to a certain degree. So we need newer materials that will be more biocompatible. We have created now lower profile devices. We don't have challenges like we had 25, 30 years ago when we have a 27 French device for either abdominal or thoracic aneurysm repair. We have 14 French devices. We have 16 French devices. So we have overcome that obstacles, but not all of the other ones that we still need to work on with
Sure.
better materials and more durable materials.
Well, they say artificial intelligence is affecting everything in technology. When you talk about custom graphs and not knowing how the os are going to move around to the branches, I mean, it seems like that's ripe for AI, for new materials that have biological properties. I mean, AI. You've written about this in the past. What do you think? What do you think the future is going to be? How's that going to affect everything that you do?
So I got involved in this very early and I got very much interested in it, researched it quite extensively and published in Texas Art Institute Journal a couple of articles related to it 4 or 5 years ago. And when I look at that article, it's so outdated. It's like having something available otherwise in the literature that's 20 or 30 years old. There is so much of movement in this field. It's absolutely amazing. Another article that I wrote is the use of AI in education and credentialing, which definitely will take over in what we do.
Absolutely.
But what we need is more investment. This field is extremely, extremely costly and expensive. And so it is very difficult to encourage the industry to embrace it in full power. And this is where we need more influx of money to be able to do that. As you know, you're involved in robotics and a lot of other things. The ideas are there. We know how to create those algorithms. But the question is, how fast can we do that? Because, for instance, I'm using certain technologies, AI technology, for predicting the risk of TAVR procedures, percutaneous aortic valve and mitral valve repair. How will it behave in certain anatomy when you have severe calcifications, severe stenosis, risk of occluding coronary arteries, perivalvular leaks, and so on. We already have AI algorithms that can predict it pretty reliably. Now we need to expand it to all the other applications in the not only vascular, endovascular field, but also surgical field. And this is where a lot of things are happening right now. I mean, imaging is full of it as far as AI is concerned. And it's rapidly expanding and evolving in this field.
And it seems like in some areas of engineering, some pursuits, AI is having more of an impact and going faster. What's the resistance in medicine, do you think?
Well, there is always resistance in medicine. For instance, I have very challenging times sometimes to teach my associates and also fellows how to embrace certain devices for, let's say, access repair. We have now 5 or 6 different large bore access repair devices, and they get proficient with one, and they don't want to change to another one, even though the success rate could be significantly higher. So there's a certain resistance, and some individuals are more prone to that than the other ones. And so to overcome that obstacle is a challenge at the present time.
I think in a technically oriented field where if things don't go well, the consequences are so dire. When someone's comfortable with something that they can get it to work, getting them to abandon that and try something new, there's a lot of resistance. I know when we were trying to advocate for off-pump coronary bypass, there was a lot of resistance from surgeons. And so I think it's just that, you master a technique and it's hard to budge off that.
But newer generations, they're used to playing those games, video games, and they're computer savvy, technology savvy, and so on. They probably are significantly better in robotics than some of the individuals from way back that have never done anything like this. So those are the challenges.
Which begs another question. I mean, I'm not going to say you're old, but you're older than me. You were talking about stuff you did in 1970, and I was going, God, I was 10 then. And yet you're still so energetic. You're still embracing new technology with greater facility than just about anybody I know. What's your secret? What's kept you so energetic and going? And how long are you going to go? I know in Houston, 95 is considered mid-career. What's your plan?
Well, being among luminaries like Dr. DeBakey, Dr. Cooley, George Rule, Willerson, Ted Dietrich, and you, I mean, this is an incentive. This is a stimulus. I mean, I'm really in a mecca of vascular, endovascular, and cardiovascular interventions and inventions, okay? So it's almost like being a kid in a candy store.
Yeah.
I mean,
It's been like a renaissance, hasn't
exactly,
it? And
exactly.
your career has been sort of a big part of that.
So, of course, you are part of the reason we work on several projects together, and it's absolutely exciting. I mean, to be innovator. And I think that, you and me, we have a lot of different areas of interest, and so I never get bored. And this is one of the reasons that I still enjoy life.
That's the one thing I'm most fearful of is boredom.
Exactly.
And so I've tried to craft a life that avoids that, and I think we're kindred spirits in that regard. Well, endovascular surgery, there was no such thing as endovascular therapies when you started off. I certainly had never heard of it. Now, new things are coming out all the time, the percutaneous valve repairs and all the tricuspid stuff, and now stuff in the brain. The sky's the limit. Where do you think it's all heading? Do you think surgery is ever going to be obsolete?
Well, I have to say, the endovascular interventions would not have evolved without vascular and cardiovascular surgeons leading the field. Mm-hmm. Dr. Cooley and even Dr. DeBakey, Dr. Dietrich in particular, mm-hmm. was a product of this environment.
Sure.
And you as well,
thank you,
have helped tremendously to move this field forward. So this would not have happened without it. Interventional cardiologists would not have existed if there would not have been some stimulus from other areas of vascular and cardiovascular surgery. So, of course, we have to be thankful to Charlie Daughter as well.
Sure.
Interventional radiologist. And
Fogarty, the first balloon.
Fogarty and Grunzig, who was a radiologist first
Grunzig,
and then became
of course,
a cardiologist. All of those luminaries contributed a great deal. But I would say, as far as the future is concerned, future is bright. No doubt, as far as endovascular interventions are concerned. There was always going to be need for surgery, but less. There will be a need for certain scenarios where endovascular technology cannot do exactly the same thing.
And there will be new surgeries.
Yeah, but the technologies are evolving, so I cannot predict what's going to happen. For instance, a few days ago, I had a physician that came to me with aortic valve stenosis, critical aortic valve stenosis. Mm-hmm. And he had what we call a very high Agatston score, tremendous calcification, 6,000 Agatston. This is probably as high as you can get it. Mm-hmm. And at the present time, the risk of doing TAVR in this type of scenario is occluding the coronary arteries, embolizing everything, and so on, and having less than optimal results.
Right.
So there is no technology at the present time that can safely offer endovascular approach. It's not that it's not doable, but it's less optimal than surgery would be. Mm-hmm. So there will be always scenarios like this. The main issue and the challenge is, how do we maintain skills as cardiothoracic surgeon to do efficiently those surgeries that are now predominantly being done via endovascular approach.
Sure.
You cannot do one a year or two a year. You have to do a lot of them.
And all the easy things have gone to endovascular. So every operation now is a fastball to the head, and the volumes have gone down. How do we maintain
exactly that is
not
only for you to maintain the skills, but how do you train the future cardiothoracic surgeons to be proficient? And will you get enough of trainees, because they'll realize there is not much work for me. I better get some endovascular skills. And we have seen that in our program where, the residents from our cardiothoracic program come to me. They will not hire me unless I gain some catheter-based skills.
Right.
Right. So there will be a hybrid approach to anything that we do, but some surgical skill will be needed. If nothing else, for repair, when we fail something, and which
Sure.
might happen in 1 or 2% of cases.
Sure.
But when it happens, it could be tragical if we don't know how to intervene.
Yeah, I think there's a quote, and I think it's false, but Charles Duell, who ran the patent office in 1900, looked around and said, "It's difficult to be an inventor in 1900 because everything's already been invented." And I think it's easy for people to say, "Well, God, endovascular therapies, it's mature. Everything's been done." I'm guessing the most amazing endovascular technologies have yet to be developed. And over the next decade or two, and partly with AI as a tool to develop those, I think the only thing you can predict from life is change, except from a vending machine. I've really enjoyed this interview. I've always looked at you as a leader, a legend, and an inspiration, and hearing some of the stories from you has been wonderful. And thank you for letting me play interviewer today, and thank you all for listening.
Thank you very much.
Thank you, Penumbra, Innovating with Purpose, for sponsoring and supporting this episode.